So let's finish up these last three elements of our 12-lead ECG interpretation. We know rate, we know rhythm. We'll review those briefly at the end. And these last three, axis, hypertrophy, and infarction, are a bit more cut and dry and perhaps a bit more obvious than rhythm was. Rhythm has some interpretation to it. Axis and rotation, it's a nice, clean, easy example and method of assessment. And so what do we mean by axis or rotation of the heart? Really, we're assessing axis and rotation of the net electrical vector of the heart. It's not that the heart will physically move, although there might be some angling within the chest cavity, but there's not a large deviation in the structure and location of the heart for the most part. What we're measuring is the net electrical activity. And so we want to use the most easily identifiable piece of the electrical activity puzzle, the QRS complex. Now that normally is a straight shot down the septum. It shows us where the apex of the heart is pointing, and that's what we use for our net electrical vector. And so for axis, we're thinking clockwise or counterclockwise angling of that vector in the chest. So we want to use limb leads for that. No chest leads. They're coming up. So frontal plane, that splits the body into forward and posterior sections, 6 limb leads only, and we use what we call a hexaxial reference system to determine the general location and then the specific angle of that vector. And that's not supposed to be clear yet, but we'll go through examples about what that is and how to use it. So we ballpark the angle first, and then we assess the, I want to say the degree, the angle. We get a pretty good idea within that general ballpark what angle the heart is pointing, the axis of the heart. Usually it's within 20 to 30 degrees. We can't get more specific than that, but we can use what we call these isoelectric waveforms to have a better idea than simply it's pointing down to the left or up to the right. We'll get a pretty nice detailed example using these waveforms. So recall our 6 limb leads. We use the 3 electrodes on the upper body, 2 on the shoulders, 1 at the lower left, and the projections from those leads. We have the physical leads that connect 2 electrodes, and the theoretical or hypothetical leads, the augmented voltage leads, which combine information from 2 neighboring vectors, 2 neighboring leads. So we have this really complex picture of the electrical activity in the frontal plane, and that makes a really nice starting point for trying to figure out the axis and angle of the vector of the heart. This is the basis for the quote-unquote hexaxial reference system. So we'll work our way up to that very detailed circular plot, but what we do first is ballpark the quadrant. So I'm using the 6 limb leads. I'm not showing a few of them now. I'm just using the main, what I'd call cardinal leads, the X and Y axis, which are lead 1 horizontally and AVF vertically. And there's a bit of interpretation here. AVF isn't exactly vertical, but for our purposes in determining axis, we assume that it is. And using only these 2 leads, you can figure out the general area where the net vector of the heart falls. It's quite straightforward. It's easy to even eyeball. Now normally we expect there to be some down to the left orientation. The heart is rotated that way. It points towards the lower left side of the body. And if that vector falls within the lower left quadrant, lower right as you look at the slide, but assume that a person is standing in front of you and this is overlaid on top of them. So imagine it overlaid on top of my chest up here. If it's pointing down and to the left, we consider that normal. If it's to the right, we call that right axis deviation. If it's to the left, so even a bit superior, it's left axis deviation. And extreme right axis deviation is listed, but incredibly rare. This is electrical no man's land. To complete the picture, we need to show it, but you'll hardly ever observe the net vector going up and to the right, a complete 180 from what it's supposed to do. It's very rare. We won't even address it. So if we want to determine the quadrant for our net vector using the QRS complexes, all we need to rely on is our understanding of upwards and downwards deflection of the signal when reading from an electrode. We know depolarization is a positive wave towards a positive electrode gives an upwards deflection. So if the heart is depolarizing, the net depolarization of the heart is towards lead 1, the QRS complex points up. If it's towards AVF, the QRS complex points up. If it's pointing up in lead 1 and AVF, that means that the net vector is heading towards both of them at the same time. And that's entirely possible. Right? Think about biomechanics. You'd have a net vector with some angle theta, and you would do the vertical and horizontal projections of that vector. I see some eyes glaze over. It's pointing towards both lead 1 and AVF at the same time, so the QRS complex points up in both of those leads, or for both of those traces. So you can look at a 12-lead ECG trace and instantly ballpark the quadrant, no problem. Well, what happens if it's right axis deviated? Net vector is it towards or away AVF? Towards AVF. Is it towards or away from lead 1?
Away.
Away. So we expect an upwards deflection in AVF and a downwards deflection in lead 1. It's as simple as that. Positive wave away from a positive electrode gives a downwards deflection. And so you can see what's coming. You follow this through logically to completion. Left axis deviation. The net vector is heading towards lead 1, but away from AVF. So we have a corresponding upwards deflection in lead 1 and a downwards deflection in AVF. And if you ever find the rare example of extreme right axis deviation, if you can search out Bigfoot, downwards deflection in both lead 1 and AVF. You'll never see this. Hardly ever see this. So if we have our 12-lead ECG trace and we can identify lead 1 and AVF, we can ballpark the quadrant. No problem. Now, what this doesn't tell us is in this 90-degree span where the vector lies. It doesn't. You might be able to interpret if it's closer to lead 1 or closer to AVF by the relative sizes of the QRS complex, of the amplitudes. But if we want to get a better picture, an accurate assessment of the angle within this quadrant, we need a bit more information. And to understand that information, I want to go back to basics for a second. So this is nothing new. We have our lead, and it's horizontal, so I'm going to call this lead 1. We already know, because we just did it, and we've seen it in previous classes, depolarization towards the positive end gives an upwards deflection. Depolarization away from the positive end gives a negative deflection or downwards deflection. What happens if depolarization is neither towards or away from the positive electrode? In theory, what would happen if it were exactly perpendicular to lead 1?
No deflection.
Pardon me?
No deflection.
No deflection, exactly. In a perfect scenario where all the activity was exactly away from the main plane of lead 1, we wouldn't register anything. There would be no deflection. In practice, in the heart, and if you think about the net vector being both ventricles contracting, the ventricles don't lie along one two-dimensional line. It's impossible for there to be no deflection. But it is possible for there to be no net deflection. So in practice, what we see is a balanced QRS complex. Some electrical activity will be captured heading towards the positive electrode. Some will be captured heading away from the positive electrode. But the net direction will be balanced. For this to be a perpendicular depolarization or a perpendicular vector, it has to be balanced by definition. The net vector is perpendicular only if the activity on each side is balanced. Question? Yeah.
Wouldn't another lead just pick up on that depolarization?
It would?
Okay.
Yeah. Another lead would register more signal towards or away from the positive electrode. So if you went to, bear with me. That's interesting. Nope. There we go. If you used AVR, for instance, it's slightly oblique to lead 1. Then there would be some directional implication. It would be towards or away from the positive electrode of lead 1. But we don't want to know that right now. We want to identify the isoelectric lead because that tells us which lead is perpendicular to the vector. Other leads will give us directional information, but we don't want that. We want to know which is perpendicular to the vector. I'll show you that on the next slide. I hope that's clear. The problem with using other leads that will show the direction is there's no way to differentiate between two that say net depolarization is heading towards both of them. You can't say which one it's closer to. So we want to find which lead it's most perpendicular to and then assess the vector accordingly. It's easy to tell which one is perpendicular. It's easy to see which one of these is balanced. It's hard to discern which one is seeing more of the signal. It could be amplitude, it could be placement of the electrodes. So the net vector is balanced and necessarily is perpendicular to whatever lead generates this trace. So we know that in the heart, the net vector is through the septum. So if we have some perpendicular lead that gives us information with a trace like this that's balanced top and bottom, that identifies where the vector is, that identifies that blue line, the net vector of the heart. We just need to know which lead, which trace is perpendicular, and that will give us the net vector of the heart. So let's follow up with our hypothetical example. We've ballparked the quadrant, and let's say for argument's sake that the QRS complex is towards lead 1 and AVF. So we know it's in the normal quadrant. We don't know where it is in the normal quadrant, but we know it's somewhere in the normal quadrant. Now I'm going to overlay the rest of the limb leads. This is the hexaxial reference system. Just a bit more detail on the quadrants I presented last time. We still have lead 1 horizontally. We still have AVF vertically. And then if you just took the rest of the leads and superimposed them, you can see lead 2, which is kind of down to the left, AVR, AVL's up here, and they're each associated with some degree of orientation, some direction. And this is fixed. The reference system doesn't change. Lead 2 is downwards at a 60-degree angle. AVR is down to the left at a 30-degree angle. Lead 1 is perfectly horizontal. You don't need to memorize this if this is on a midterm or final. I'll give you the system so that you can see all of these angles and the leads that are corresponding. But what's important is being able to discern the net vector or the direction of the net vector. So we have normal deflection down to the left, lower left quadrant. Let's say that on my ECG trace, the most isoelectric lead is lead 3. So I'm reading lead 3. The QRS complex is balanced top and bottom. That means the net vector is perpendicular to lead 3. So I would say deviation is 30 degrees. The axis of the heart is in the normal quadrant at 30 degrees. Because lead 3 is most perpendicular, I know the net vector has to be away from lead 3. If we were just to look for the most isoelectric lead, we wouldn't know if the electrical activity was 30 degrees or negative 150. Because we've ballparked the quadrant already, we know that it's heading towards lead 1 and AVF. We've isolated this quadrant. We've ignored the other quadrants. We know that it has to necessarily be 30 degrees. Similarly, if AVF was the most isoelectric, and that's entirely possible. If AVF were the most isoelectric, then the net direction is 0 degrees towards lead 1. If the most balanced electrode were AVL, 60 degrees towards lead 2. So understanding that if the net vector points away, perfectly away from one lead, we should register no activity, and we'll register no net activity, equally balanced top and bottom. Quadrant tells us the direction, and then the isoelectric lead tells us the angle. And it's also possible if lead 1 is the most isoelectric, and it's at 90 degrees. You'll only ever use one series of these leads, depending on the quadrant that you're in. If we're in the normal quadrant, there's only 4 possibilities. And while we say this is a specific look at the axis of the heart, there are still plus or minus 30 degrees of error between each of these. It's usually possible to see one isoelectric lead, but sometimes you'll just have to give it your best guess. If it's pretty close to lead 3, then you can say it's around 30 degrees, but I'd never expect you to say it's 55 degrees or 27 degrees. You can't get that specific. So if I'm in the normal quadrant, I only use these. Ignore the rest. If I were in the left axis deviation quadrant, the perpendicular axes are lead 1, AVR, 2, and AVF, telling me whether it lies on lead 1, at 0 degrees, negative 30, negative 60, or negative 90, and then so on and so forth. So we have a pretty comprehensive view of the net axis of the heart, just following this easy stepwise progression. And it sounds like a lot, and it looks like a lot, but let's work through an example so you can see how easy it is. Step 1, what do we do? Define the axis of the heart. What am I doing?
Look at the deflection of the QRS complex?
Yes, where?
At lead 1 and
Lead 1 and AVF. Yeah, exactly. Lead 1 and AVF. So lead 1 being horizontal, AVF being vertical, they are here and here. What is the QRS complex doing in lead 1 and AVF? Deflecting upward. In both?
Yeah.
Okay, so what quadrant are we in?
Normal.
Fantastic. Normal quadrant. We've eliminated the other 3 quadrants. We know to only focus on the normal quadrant. I probably should have found a better example that is different than our setup, but the process is the same. So it's down and to the left. Normal quadrant, and you might have to look back to the reference system to figure out the angle, but we don't need to look very far to figure out which lead is most isoelectric. We want to find the lead that is perpendicular to the net vector of the heart. So which one would you say is most perpendicular? Which QRS complex is most perpendicular?
Are we always referencing like lead 1 and AVF, like when we're trying to identify?
Yes.
We're always choosing those two.
Lead 1 and AVF are the cardinal leads. They make the X and Y axes of the reference system. They're horizontal and vertical. Always lead 1 and AVF. And the degrees are always the same too. So, of these limb leads, which one is the most isoelectric? AVR, I hear. Okay, so we're up here. Is this most isoelectric? Where's the net deflection of the QRS complex?
It's down.
Mostly down.
Probably V4.
V4.
We're staying away from the bottom.
Excellent. That's tricky. Yes. This is very isoelectric. It's balanced top and bottom. But why do we not want to look at this information when determining axis?
So it's on the horizontal.
Yes, it's on the horizontal or transverse plane. This doesn't tell us the angle, the clockwise or counterclockwise rotation of the heart. Clockwise or counterclockwise axis of the heart. This tells us rotation, which is the next half. That's coming up. So we only want to look at the limb leads. We want to look at the left-hand side, the left 6 leads of our 12-lead ECG trace. Which one is most isoelectric?
3.
Probably lead 3. It's not exactly isoelectric, and that's fine. We don't have the ability to be so specific with our determination of the angle. We just want to know that, oh hey, it looks like it's closest, or it's most perpendicular to lead 3. And if we look back at the reference system, if the net vector is perpendicular to lead 3, that means the axis is 30 degrees in the normal quadrant. It's the best fit of the 6 that we have. I think in order it might go lead 3, then AVL, and maybe lead 2, but it doesn't matter. It doesn't matter what the order is. Lead 3 is the best representation. We don't want to look at V4 because that's our interpretation of the rotation of the heart. We're not looking at clockwise and counterclockwise deviation. We're not looking at the axis in the frontal plane. We're looking at rotation in the horizontal plane. And here, we use the same approach. We want to find the most isoelectric lead to identify the rotation of the heart. Now this is a little bit trickier to imagine. In the last example, where we had leads in the frontal plane and the vector was in the frontal plane, it was along one of those leads, the most isoelectric lead indicated where that vector was perpendicular. But a vector isn't only perpendicular if it lies within the plane. Imagine now those leads are coming out of the screen towards you. A perpendicular vector can still be down and to the left and registered on these horizontal electrodes. We don't need to ballpark the quadrant. We just want to find which one of the chest leads is most isoelectric, identifying the rotation of the heart. This is still in relation to the net depolarization of the ventricles. It's just in a separate plane. It's not in the same plane as the leads that we're reading currently. So we can only tell if the heart is rotated rightwards or leftwards, or if it's normal. We can't tell if it's extremely rotated because we don't have a full 360-degree circumference of the chest leads across the heart. We have from just on the right-hand border of the septum to the axillary axis on the left-hand side. So we don't encompass the entire body, but we can tell if the heart is rightwards or leftwards rotated. V1 and V2 look at the right-hand side of the heart, like we already know. V3 and V4 are through the septum, indicating balance. And then V5 and V6 look at the left-hand side of the heart. So if the most isoelectric lead is in V3 and V4, it's normal. If it's shown in V5 or V6, it's to the left. Or V1 and V2, it's to the right. And I'm hoping that if I just throw this figure up again quickly, it might help to reconcile the idea that now we have these horizontal leads coming out of the screen towards you. The net vector is still perpendicular to that plane. It's not going to be exactly perpendicular to all of these electrodes because the heart is angled slightly. And then you can imagine if this is the normal scenario, the most likely perpendicular leads are V3, V4. The information, the signal is going towards V5 and V6 because it's angled to the left, and away from V1 and V2, again, because it's angled to the left. So we've had the example spoiled for us. This is the same trace that we just looked at where we identified the heart is normally rotated at 30 degrees. The axis of the heart is normal at 30 degrees. I often use axis and rotation interchangeably, but I'm going to try to make sure I don't do that. The axis is normal at 30 degrees. How is the heart rotated? Now we look at the chest leads to find the most isoelectric. V4, as we saw before, is the most isoelectric. V4 is the most isoelectric, meaning the net vector is perpendicular to V4, and the heart is normally rotated. It's neutral, if you will. Let's maybe jump. I'm going to jump like way ahead. Let's try another example, because this one works out too nicely. Let's look down here at the end of the slides. This is infarction, but we're not going to look at infarction currently. Let's see if we can figure out axis and rotation of this example. So let's start with axis. Clockwise, counterclockwise, what quadrant are we looking at? So what are our two candidate cardinal leads? One in AVF. So what quadrant would the net activity of the heart lie in here? Can I give it a shot, was on? One in AVF?
I'm confused, I'm just trying to...
Okay, let's figure it out. Where's lead one? Right here, okay. So I want to know if the net vector is heading towards or away from lead one. So I'm going to look at the QRS complex. How does it look? What's its shape? Upward. Okay, so is that depolarizing towards the positive electrode of lead one or away from the positive electrode of lead one? Positive wave, something, a positive electrode gives an upwards deflection. Fill in the blank, towards or away. What else would you guess? Towards, yes. Positive wave towards a positive electrode gives an upwards deflection. So it's towards lead one. Who wants to try AVF?
Because the net is upward.
Net is upward. It's mostly upward. There's some going away, but it is definitely weighted towards AVF. So again, normal quadrant. Fantastic. Let's figure out the axis, the most isoelectric lead to give us the angle of the axis of the heart? AVL. Everybody agree with AVL? Yeah, I agree with AVL also. Equally balanced, top and bottom. I hope this works out. This is sort of off the cuff. Let's find out if AVL works. AVL, yeah, okay. So the most isoelectric lead is AVL. That means the heart's axis is 60 degrees. The most isoelectric lead, you can see AVL here, kind of pointing down and to the right if it's superimposed on a person. Means the heart's axis is 60 degrees. There we go. It's hard for me to see at this weird oblique angle. Okay, so we've done that. Let's figure out rotation. Can we figure out rotation? This is a really good infarct example. Bad example for rotation. But let's try to assess rotation. Yikes, okay, that's not even really possible. What would we look for?
Isoelectric in the horizontal plane.
Most isoelectric lead in the horizontal plane. So along these chest leads, V1 through V6 on the right-hand side, they're all pretty weighted one way or the other as a result of the infarct, so it's not possible to make out the rotation here. If we had to guess, is that what you're going to do?
Yeah, I was gonna say, if they're all like that, could you just assume that it's normal then? If you have like two negatives make a positive kind of.
Okay, good question. If they're all weighted one way or the other, could you call it normal? I don't think this is the right way to approach it, but what I would do is take the net sum of the directions. So if they're all weighted one way or the other, I would tally the votes. We have V1 and V2 not isoelectric, so away from V1 and V2, away from V3 and V4 because they're also downwards deflected, but towards V5 and V6. So I'd say that it's not neutral. It's also not leftwards rotated, but it's closer because somewhere between V4 and V5, if you had that fine measurement, it would flip from downwards to upwards. It would flip somewhere between V4 and V5, so the most isoelectric lead would be between those two somewhere. Yes?
So
Question in the
just to
back.
clarify, you would find the most isoelectric chest lead, and then if it was, like, how would you know if it was left or right? Like, if it was just which chest lead was the one that was isoelectric? Is that all you do?
It is which chest lead is isoelectric. Yeah. Because it's most perpendicular to that lead in the horizontal plane. The vector points down through the horizontal plane, and we're trying to figure out which one is most perpendicular. Just exactly like you said. Yeah. Yeah, if you follow the progression, it's somewhere between these two. But it's also entirely possible that the electrical activity is skewed by the infarction that we're going to talk about later. Yeah.
How can you tell if, like, when you're saying that the lead is, if it's towards or away from the lead, like, how can you tell from this picture?
Okay, how can you tell if the signal is heading towards or away from the lead? The intrinsic nature of reading the electrical activity using positive and negative electrodes. Depolarization is always positive, and if a positive wave goes towards a positive electrode, it's always an upwards deflection. It's like adding and subtracting integers. Adding a positive gives a positive. Adding a negative takes away a positive. So positive wave towards a positive electrode, and all of these chest leads are positive electrodes. If it's an upwards deflection, it's towards the lead.
But these are all downward.
If it's a downwards deflection, it's away from the lead. So it's going out the back.
And then all the chest leads are negative, not positive. So it's like,
Most of the chest leads are negative. V5 and V6 show upwards deflections. So the bottom two, the depolarization is heading towards the bottom two, which are actually on the left-hand side in the armpit. And then the top four are more anterior. It's heading away from those four. Yeah.
If you were to have all 6 be negative, going towards the back,
Ooh, all
you
6.
see the heart was tilted, like,
That's a fantastic question. If all 6 are negative, the net vector has to be moving away from all 6 electrodes. I don't think that's a normal situation, and there's likely a disease state happening there. And actually what we'll see, the infarction example will probably address that because we're looking for movement away from an electrode to diagnose the infarction. We'll get there. But let's put a pin in that. I think that's a really interesting question. I don't know the answer off the top of my head. For axis and rotation, though, isoelectric leads are perpendicular. We're building on our knowledge of the directionality of the waves towards or away from the positive electrode. If it's neither towards or away from the positive electrode. Therefore, it's perpendicular. When we're trying to figure out axis, step 1, figure out the quadrant. You always use what I'll call the cardinal leads, the horizontal and vertical leads to do that. Lead 1 and AVF. Then, the quadrant tells you the direction, and if we try to find the angle within that quadrant, the most isoelectric lead allows us to discern that from the hex axial reference system. You don't have to memorize that lead 3 is 30 degrees or AVL is 60 degrees. That would be on the system if I put it on a midterm or a final. Lastly, rotation. Same exact principle. The most isoelectric chest lead in the horizontal plane determines the rotation of the heart as the heart depolarizes vertically, perpendicular to the horizontal plane. The most isoelectric identifies the rotation. Normal or neutral, V3, V4. Right or left, V1 to V6. Okay, let's move on because I want to finish these 3 today, and I don't know, I think that's probably possible, but we'll see. Hypertrophy. Hypertrophy, what do we mean by hypertrophy? Enlargement of the heart, or accrual of cardiac tissue. It's usually a symptom of exercise training. If you regularly increase heart rate, the heart will boost its resources accordingly. Or disease. If you always have to pump blood against a higher pressure gradient, if you have high blood pressure, or against high systemic pulmonary pressure, if you have COPD, the heart will respond and adapt accordingly. So hypertrophy is not always good, but it comes about when the workload of the heart is increased past normal. And hypertrophy can occur in the atria or the ventricles, combined or on one side or the other. Generally for the atria, they're supposed to be balanced. The atria don't need to do a lot of work. Pressure in the atria is always quite low. The filling of the ventricles is done almost passively, and then the atria just give a little squeeze to add more blood to the ventricles. They're generally balanced. If they're not balanced, you'd see that as a biphasic P wave. We use specifically V1 to look at the atria because V1 has the best view through both atria. It's the closest electrode that can look through both atria, the right and the left. Normally, we see one uniform P wave as both atria contract simultaneously and equally. But if the right atria or the left atrium is stronger, we'll see this biphasic response. And so think about being the positive electrode of V1. If the right atrium is stronger, there's going to be more activity coming towards the positive electrode of V1. and less going away, less going towards the left atrium. And so we see this emphasis towards V1, indicating right atrial hypertrophy. Comparatively, if you're the electrode V1 and you see more activity heading away from you, that probably means the left atrium is more electrically active. And we're using electrical activity as a surrogate for size. Right? The entire tissue should depolarize. If there's more signal, that means more tissue is depolarizing. There's more signal away from that electrode, it means there's more tissue in the left atrium. But normally we would expect these to be balanced. Equal signal towards and away from V1. And that's all there is to atrial hypertrophy. It should be balanced. If it's weighted upwards, it's towards the right. If it's weighted downwards, it's away from the right, away from V1 towards the left. Yeah.
How can you tell the difference between them both being hypertrophic or not at all? 'Cause they both
That is a good question. You can't. If they both increase or decrease in size, the waveform would still be neutral and balanced. Interesting perspective. Yeah, you can't. As far as I know. Maybe you can, but I don't know how.
Would it be something that you'd have to do like chronically, like over time, if you were to be following somebody with a condition that would cause ventricular and atrial hypertrophy? To compare it to like their former ECG?
So with this, the atrial hypertrophy or the ventricular we'll talk about next. If you followed someone over time, you could see the progression as it went from balanced to weighted up or balanced to weighted down. You can see the development of the atrial hypertrophy.
I was just commenting if like they were both larger than like they used to be. Like would the depolarization increase? Like would it be more aggressive upwards and downwards, or would it be like relatively the same?
That's a good question. Would it be more aggressive? I would imagine if you had more heart tissue, if you had atrial hypertrophy that was balanced and equal in both, it would probably be more aggressive. Yeah, you would see a greater spike and trough. And if you had a baseline to compare that to, you might be able to make a guess at if both were becoming larger. Yeah, that's a really interesting point.
And are there
Yeah.
equations, like if you weren't able to follow somebody for that long? Or if like they just come in and they're like, I feel weird. And then you can maybe look at like a standardized ECG screen for that person's like age, gender, weight.
The short answer is I don't know. Are there standardized tables or equations? I don't know. If I were studying this area, I would want to do that. I would want to find them, or that would be a great next step. Absolutely. If you have a calibrated ECG trace where you know the height of every box is 1 millivolt, and then all of a sudden you register these spikes and troughs on V1 to indicate there's a lot of activity in the atria, I'd like to be able to say that, a 3 millivolt box equals hypertrophy. There's probably something like that. I'm not familiar with it though. That's a great idea. Yeah. Yeah, because the size of the amplitude indicates the amount of the signal. And if there's more signal, more mass, there's got to be some threshold where it transitions from normal signal to too much. Normal tissue to hypertrophy. Okay, so let's reframe this section as imbalance between the atria. Okay? Imbalance between the atrial muscle mass. Normally there's balance if it's isoelectric, if it's weighted upwards, right atrial hypertrophy, downwards, left atrial hypertrophy. Yeah?
But what would cause there to be an imbalance in the hypertrophy of the atria?
So anything that would cause the atria to contract more forcefully would increase the size and the work of the atria. So something like the mitral or the tricuspid valves being stenotic or really firm and not labile.
So if that happens on one side versus the other, then
Yeah.
okay.
Yeah, if one of the valves on one side only is hardened and flexible, the atria would have to pump harder to move blood past it. Think of the obstruction with the FVC test, how it should have worked. If you block off 3/4 of the tube flow is impeded. And so you have to push harder to get the same amount of air out. Same thing with the atria. Good question. Yeah. More. Yeah, fantastic.
Is hypertrophy typically more so in one atrium than the other, or is it like?
I don't know whether it's more typical in one atrium versus the other, but certainly in the ventricles, there's often left ventricular hypertrophy. The atria, I don't think we can say one's more common, or at least I don't know if one is more common than the other. I like it. You guys are into the material. That's good. So let's talk about the ventricles then. Unlike the atria, the ventricles are not balanced. Atria should be balanced and of the same size, generating similar amounts of electrical activity. The right ventricle, however, is usually smaller or thinner than the left. And that's simply because it has to do less work. The right ventricle pumps blood to the pulmonary circulation, which has one of the lowest flow rates and pressures of anywhere in the body, if not the lowest pressure of anywhere in the body. So it doesn't have to do very much work to pump blood into that pulmonary circulation. So it's often much thinner than the left ventricle. But any situation that will increase pulmonary resistance, increase the pressure in the pulmonary circulation, will make the right ventricle do more work. So at high altitude, we can see some collection of fluid and edema in the lungs that can squeeze the capillaries. Right ventricle has to do more work. COPD, if we have increased pressure in the alveoli, the alveolar sacs, that can block off some of the capillaries. Increasing pressure, right ventricle has to do more work. If the pulmonary valve, so the outlet between the right ventricle and the pulmonary circulation, if it's stenotic, if it's not working properly, if it's obstructed, right ventricle has to do more work. And so we assess the right side of the heart primarily in V1 and V2, our chest leads that divide the heart into left and right compartments. If the right ventricle is larger, if there's right ventricular hypertrophy, the activity on the right side should be larger than normal. And so what is normal? Normal is shown on the top, and when I think of normal, I'm thinking of progression. We can take measurements, and I'll show you those in a second, but consider the progression as you move from the right to the left. The left heart, the left ventricle, generally more active, larger, stronger, should demonstrate more activity. And so we see an increase in the QRS complex as you move towards the left side of the heart. More activity pointing that way. There's also some troughs in V1 and V2. That just simply means it's picking up the activity, moving away from V1 and V2. But this is the normal progression. Weaker right side, stronger left side. If the opposite is true, as is shown on the bottom, we have much higher amplitude in the QRS complex on the right side with V1 and V2, and that progressively decreases as you move to the left. That means the activity and the size of the heart also decreases as you move to the left. Here, we have standardized tables. We have things that we can compare the amplitudes to. So I imagine if we have them for this, we'd probably have them for the atrial hypertrophy that Sadie was mentioning. But if the combined, I guess it's not combined, if the R complex, if the R wave is over 6 millimeters high, indicating 6 millivolts of activity, and the S trough is lower than 2 millivolts or 2 millimeters, indicates a strong rightward shift or rightward preference of the electrical activity in the ventricles.
Why wouldn't you see like the left ventricle, so V5, V6, remain the same size as normal?
why wouldn't you see it remain the same size? I think what we're seeing here is the overshadowing of V5 and V6 by the activity on the right-hand side. So consider two depolarizations heading towards each other. Two waves heading towards each other would make a larger wave. Oh wait, let's think about it this way. You have electrodes on either end of one lead, and you're reading the activity heading towards the right-hand side. You see an upwards deflection on this lead. If you have a complementary electrode on the other end of that axis, you're going to see a downwards trough as that depolarization moves across. If there's two moving together, you see nothing. The net activity balances each other out. The upwards deflection and the downwards deflection as you move towards and away from each electrode cancels each other out. So here what I think we're seeing is the contraction of the left ventricles is overshadowed by all of the activity on the right-hand side. There's a lot of activity moving away from V5 and V6. That just means there's more activity away from V5 and V6. It's rare, and I don't think that we'll ever see such a large trough on the left-hand side because normally it's way bigger. It's a stronger ventricle. But this just means that there's more activity moving away from the left side of the heart. You see this large trough on the left-hand side.
So we normally see more of it, like an isoelectronic style, like where they're both roughly the same size?
I think it depends on the progression of the right ventricular hypertrophy. At some point, if you were able to follow someone from a healthy baseline through the development of right ventricular hypertrophy, you wouldn't just jump from the top to the bottom. There would be a gradual progression from the trace on top to the bottom. So you'd see this gradual redistribution and reorganization of the QRS complex where it gets larger on the right heart and gets smaller in the left heart. It's not just going to flip and become negative, but depending on the severity, there might be no progression, and gradually this is severe right heart hypertrophy where it's overridden in the left heart. It's a good question. So this is the extreme to articulate the idea that we can observe right ventricular hypertrophy by measuring the amplitude of the R and S complexes. So similarly, left ventricular hypertrophy magnifies the existing inequality between the ventricles. Left ventricle is already larger. It's naturally larger because it naturally does more work. But if it has to do an unnecessarily higher amount of work than normal with high blood pressure, cardiovascular disease, with obesity, then left ventricular hypertrophy becomes obvious. Enlargement of the heart becomes obvious. And so we still use the chest leads, but here we found the best way to assess left ventricular hypertrophy is the sum, the net deflection in V1 and V5. The net deflection in V1 and V5. And I don't know why it's not just using V5, why it's also using V1, and I assume it's something to do with measuring the activity going away from V1. But the standard going rate is to measure the total amplitude of the R wave in V5, the S wave in V1, and if they combine to be larger than 35 millimeters, this is said to be left ventricular hypertrophy. That doesn't ignore the fact that, what if the amplitudes, the combined amplitudes are flipped or opposite? I think you still need to have the progression where it gets higher as you move towards the left side of the heart. But then the magnitude here is obviously larger than normal. The magnitude of the S wave is obviously larger than normal. So this is an accentuation, if you will, of the normal scenario. And it just so happens that the diagnosis is better when you add S and R together in V1 and V5 respectively. So it magnifies the normal inequality between the ventricles. Large signal towards V5, large signal away from V1, and the combination is what we assess to indicate left ventricular hypertrophy. And that's really all there is to hypertrophy, at least from our point of view. There's a lot more that we can go into depth on. I'm sure there's some information that we're missing, but again, this is only 1 week of the 12 or 13 week class. Their entire course is dedicated to reading this information. How you doing?
Scared.
We still have class, right? Like we go until 9:30. Yeah, okay. All right, so our limited view of hypertrophy is kept to atrial balance if there is a biphasic P wave in V1. Bimodal is the notched. There's 2 modes, there's 2 bell curves overlapping. There should be biphasic, up and down. So we assess the biphasic P wave in V1. If it's balanced, the atria are balanced. If it's not balanced, there's hypertrophy in one of the atria. Right ventricular hypertrophy is the opposite progression of QRS complexes through the chest leads from right to left. Instead of increasing, it decreases. There's more activity in V1, indicating more activity on the right side of the heart. And take this with a grain of salt. You'll see this in extreme cases, but there's obviously a transition period where they will level out over time. And then left ventricular hypertrophy is larger than normal activity, or a magnification of the normal trend that we observe in the chest leads. Specifically, the S wave trough in V1 and the R wave peak in V5 added together. If it's over 35 millimeters, we call that hypertrophy. That's where our view ends. And that might not be satisfying, and I apologize if it's not. If you want to know more, that's all we care about right now. Because we still have one element left, and that is infarction, which is probably one of the coolest parts of the 12-lead ECG. We can determine if there's been infarction in the heart. And what do we mean by infarction? Myocardial infarction. You've probably heard more about it recently. It's related to atherosclerosis and cardiovascular disease. It's specifically the death of cardiac tissue. The rupture of the membranes, that's the defining factor that makes an infarction. If cardiac myocytes rupture, if they die, it's often due to inadequate delivery of oxygen and other substrates, but that tissue is rendered inoperative. So there's no electrical activity. It does not contract. It's dead tissue. So the dead tissue takes away from the signal that we would observe. So you can see the dead tissue in the top inset figure just on the left-hand side. It's a lateral infarction. The bottom figure must be looking down from the top. And I say that because the ventricle on the right of the screen is obviously larger. That's obviously the left ventricle. This is obviously the right ventricle. And so this is a posterior infarction. Dead tissue, necrotic tissue that doesn't contract. So it takes away from the activity that we would normally register. And the way that we best assess this lack of activity is in a large Q wave. And a large Q wave simply reflects a large movement of activity or a large signal away from the electrode of interest. A large activity away from the electrode of interest. So we can tell if there's a black hole of activity and where that black hole is by looking for a large Q wave. If we had an electrode behind and above this dead tissue here, we'd register a lot of activity in the septum, on the anterior wall, on the lateral wall. That would be depolarization away from and lateral to whatever the electrode was. Large negative Q wave. Lots of activity traveling away from that electrode. So imagine that we're looking, that's exactly what I'm describing. This is exactly what I just said on the last slide. Imagine we're looking down into a ventricle. This is, it looks like the hex axial reference system because I just copied and pasted the animation or the figure because it was easier than making a new one. But imagine we're looking into the ventricle, so the green rim is the wall of the ventricle, and then we have some lead that is looking through the ventricle, looking at the activity through the ventricle. If we have this electrode over here on the right, sensing activity, it's going to look like the net activity is heading away from it because there's this large necrotic dead space proximal to the electrode where we're not going to register any activity. Most of the activity is going to follow these blue arrows out and down or up, depending on how you're looking at the ventricle, but away from this positive electrode. So that's the basis for our using a large negative Q wave. Most of the activity is sensed moving away from our positive sensor, our positive electrode. So if we were to overlap this on a real heart and not use a cartoon, we can assess infarction, here represented by the dark blue, navy blue, black hole of activity. Anteriorly, we can assess a lateral infarct or an inferior infarct, where we see pronounced Q waves, activity moving away from the electrodes, immediately superficial to that dead spot. So anteriorly, that's V1 through V4, the leads on the anterior portion of the heart. Large Q waves away from V1 through V4 probably indicates anterior infarction. Lateral infarction, if we have large Q waves away from lead 1, okay, that makes sense. Lead 1 is horizontal. AVL is sort of oblique from the left arm. V5 and V6 are on the left-hand side. Okay, so left lateral infarct can be assessed by those leads, and then inferior infarct by lead 2, lead 3, and AVF. And these are generally fixed. These leads will always assess the same regions of the heart, and if there are infarctions in those regions, they'll be sensed by those electrodes. Now, the infarctions might not play ball and only stay right in the middle anterior. They might not only be lateral. They might not only be inferior. They might be two. There might be two locations of infarction. So multiple electrodes might demonstrate large pronounced Q waves. Notice we don't have posterior infarction here because we can't use the same rule. We can't look for large pronounced negative Q waves because we don't have any electrodes on the back of the heart. And we can't use an upwards deflection. If we had the electrodes V1 through V4 on the front, and you imagine this infarction on the back of the heart, and we're just looking at it, it's transparent, we're looking at it through the heart. We can't assess an infarction with more activity coming towards the electrode because that's what happens anyways, right, when the ventricles contract. So we can't use that to discriminate against posterior infarction. So we can really only assess anterior, lateral, and inferior. So now we get to the example that we brought up, that we jumped to early on in the lecture, where we're looking for infarction. And if we use large negative Q waves, relatively large negative Q waves, it looks like there's at least some small downwards deflection in lead 2, lead 3, and AVF. If we look on the last slide, that means there's probably some inferior infarction. These are larger than normal, or relatively large, when compared to the amplitude of the entire QRS complex. But certainly, there's some large downwards deflection in V1 through V4. So we have obvious anterior infarction, and probably some inferior infarction, as shown by the limb leads on the left-hand side. using the Q waves to assess infarction is it assumes that it's already happened. It assumes the tissue is dead. It's not dying. So it's not diagnostic in the sense that it can be preventative. It's diagnostic to figure out where there was a problem. So there's obviously a problem anteriorly and some small problem inferiorly. We can't say that this is ongoing. We just say it's a small infarction. But we can get an idea of whether heart tissue is becoming hypoxic and might become necrotic and might die, whether there might be infarction, by looking at the ST waves of any of the traces that we just mentioned. So the ST elevation is one of the first characteristics that pronounces with slow or delayed contraction. Slow or delayed contraction. So slow or delayed contraction will generally result if cardiac tissue is not receiving enough oxygen or fuel, the precursor to infarction. If it's hypoxic, it has a hard time contracting, and we see that initially present as an elevated ST wave as the contraction is longer and more drawn out, and repolarization takes a while to occur. Depending on the magnitude of the elevation, we can get a degree of the acuteness of the infarction. So if you see an elevated ST segment that is obvious and merges with the QRS complex, that indicates acute, I won't say infarction, but acute damage that might result in infarction, or acute hypoxia that might result in infarction. And the progression seems to be the elevation returns to normal, but then there's a negative deflection in the T wave specifically as the repolarization of the ventricles exhibits more, we'll just say problems. The progression seems to be elevation depresses, and then the negative downwards deflection of the T wave persists, and only at 1 year does it end up looking somewhat normal again. But you'll notice that we have generally more pronounced Q waves in the QRS complex as the infarction resolves. So we see acute within 1 week elevation or hypoxia by the ST segment elevation. And the T wave depression is a characteristic that will usually indicate more prolonged damage. So not necessarily 1 week, but on the order of multiple weeks to a month or a few months. And where we observe this trend, this is the progression in any chest lead, but which leads demonstrate this progression will show us not only the timeliness, the timeline of the damage, but where the damage is occurring. And like the infarction, here I'm just showing you the same information in a slightly different way. Like the infarction, if the ST elevation or the T wave depression occurs in leads of a similar color, that can give you the location of where that damage is taking place and where the infarction is likely to occur. So 2, 3 in AVF, inferior, we already talked about that. V1 through V4, anterior, we already talked about that. Lateral, all the blue regions. AVR not listed. AVR not listed because let's think about where AVR comes from. AVR comes from the right arm, and it's a combination of the lead 1 and lead 2, and generally it's through the trunk of the aorta, and it doesn't represent the ventricular tissue very well. So it could be that there's stenosis in some of the valves in the aorta, or some other problem, but any deflection here is not indicative of ventricular tissue just because of how the leads are physically set up, so we don't use AVR. Last example, before we finish everything up. This is the same thing that we just looked at, and I wanted to point out that while we do have some small inferior infarct, and I don't have the bulbs on V1 through V4 to show you the anterior infarct, you can still see the elevation, specifically in V2 and V3. V4 it's back to normal, V1 there's no elevation, indicating that there's some ongoing damage, possibly, in V2 and V3, the anterior portion of the chest, or the anterior portion of the heart, sorry. It's not so fresh, it's not in the order of hours, but probably on the order of days to weeks, because we see elevation and the trough, the downwards deflection of the T wave, indicating that it's somewhat older than the order of hours. It's not so fresh and happening immediately, but it's ongoing. So watch out for that in lab, and I hope that none of you observe ST segment elevation. Okay, let's bang off these summary points, and then we're done. Summary points, then we're done. And we're almost at the end of class. It's been a long one today. It took longer than I thought. ST segment elevation gives us an idea of the timeline, the progression. Elevated only indicates acute. Elevated plus T-wave depression indicates somewhat less acute. Only T-wave depression is a longer or further out in the timeline. When we have T-wave depression, we'll often also exhibit Q-wave pathology, large negative Q waves. Large negative Q waves indicates that some damage has occurred. There is dead tissue present. Some infarction has happened. And then in combination with the ST segments, with the ST elevation and the T-wave depression, that gives us an idea of the time frame and the progression from ongoing hypoxia to damaged cardiac tissue. The location used by that the 12-lead ECG graph that I gave you with the overlays of the location, all of those electrodes will refer to those locations specifically, and they won't change. And the infarction specifically, we use the negative Q-wave deflection to indicate that there's an absence of activity in the vicinity of that electrode. And which electrode it is will tell you where in the heart that absence occurs. All right, let's leave it there. Did you get all those points? No? Okay, I'll keep this up. The last slide's not so important, but it's just a nice way to resolve the section. We've grayed out, we've crossed out all the elements of our ECG interpretation. That was a marathon class, lots of great questions. I really liked it. Thank you so much for participating. If you have questions about this, don't feel bad about emailing. Let me know. If you have questions about the lab exam as well, not the lab exam, sorry, the lab report. We have a lab exam going on in anatomy today, which is why my lines are crossed. Otherwise, happy Thanksgiving. See you on Tuesday.
Is this the last? Is Tuesday going to be on the midterm as well?
Oh, good question. Yeah, because we have our midterm on Thursday next week. Tuesday will not be on the midterm. Midterm will cover everything up to and including this section. Ooh.